I'm David Robinson, Lead Commissioning Manager for Urgent Care in West Kent CCG, and I'm joined by my colleague Mark Whistler, who is the GP Clinical Lead for Urgent Care. We'd like to spend a bit of time with you today talking about our plans for integrated urgent care. Our journey began towards integrated urgent care in September 2015 with IC24 awarded the service for a GP in A&E, the GP out of hours and a home treatment service, which the aim was to reduce admissions to hospital. We see the next phase as a truly integrated urgent care service between an enhanced NHS 111, our local providers, MTW, the community services, mental health, social services and the voluntary sector. We're redesigning urgent care during very difficult times. We've had two very difficult winters, particularly around October to April 2017. The whole system is under pressure from reduced finances, increased activity, a depleting workforce. These factors are most evident in the A&E departments. This is not just true in West Kent, but it's a national problem. Simon Stevens, the Chief Executive of the NHS, expects improvements to urgent care by September 2017, so we've only got a couple of weeks to go. NHS England have set out a number of national initiatives, in fact mandates, to deliver changes to urgent care, and you may have heard of these: the NHS 5-year forward view and transforming urgent and emergency care services in England. So what do we mean by urgent care? So we have a very confused system, various terminology used over the last 30 years. My colleagues, I'm not old enough, but my colleagues tell me that in the 80s we used casualty. In the 90s we used accident and emergency. In 2000 it was urgent care, and in latter years it's emergency care. Our focus on is urgent and emergency care, and you can see the definitions on the screen. So urgent care is for health advice or treatments within 24 hours. Things like sprains, broken bones, fevers, sore throats and flus. Emergency care, conditions which can permanently impair or immediately endanger your life without immediate treatment, such as heart attack and stroke. I think it's important to say here that a lot of urgent care, around 80%, can be provided by your GP surgery or clusters of GPs with same-day appointments, phone calls from GPs and home visiting services. So what happens now? I think you've got Mrs. Smith in the top of the screen there. Where does she go for her treatment? Does she go to the local MIU? Does she contact her GP surgery? Does she contact 999? Does she call NHS 111? Does she go to the pharmacy, prevention and self-care? What we tend to find is that most people actually just turn up to the A&E departments at Maidstone and Tunbridge Wells. And again, as I said before, this is a national picture. The system is very confusing, it's too fragmented, usually with a number of different handoffs between services, and as a result, the majority attend A&E. We don't provide consistent 7-day services. Services are open at different times, and depending perhaps where you live in West Kent, depends on the service that you receive. We've listened to the public, the patients and other key stakeholders, including the Health and Overview Scrutiny Committee, various engagement events, and this feedback has helped in the development of an improved and more consistent integrated urgent care model. So why is change needed? I think I've given a good picture of the complexity and fragmentation of the services, and people are not always sure how to get expert advice or where to go. Society has changed. We have a right now society with very different expectations. The overall model of care has changed little, but medicine has changed a great deal. Delivery of care has changed. Paramedics and GPs can now do in the home or in an ambulance what 10, 15 years ago doctors did in the A&E resuscitation rooms. I think just some key facts. Over 1 million emergency admissions in 2012-13 could have been avoided, so you can imagine the increased numbers at this time. 40% of patients attending A&E require no treatment at all, and only 4% of emergency calls are resolved over the telephone. I'd like to hand over to my colleague now, Mark.
Thanks, David. I am old enough. I remember when I remember casualties. I remember when, as a GP, I saw 80% of urgent cases. And what I am also aware of is, over the last 30 years, it's become a more complicated, a more fragmented system. And I think now it's very difficult for a patient to know quite what to do when they need urgent care. We tried to introduce NHS 111. That's not been terribly successful. The uptake is not high. So the challenge remains, what is it that we can do to make urgent care a better service, a more rational service, a more logical service for you, the people of Sevenoaks. And we really would like you, I would like your feedback on the proposals that we're putting forward today. So, what will be different? I'm going to use this as a summary slide of the stuff that I want to go through today. What we're hoping to do is reduce the points of entry into the urgent care system down to 4 easily accessible points. We want to strengthen urgent care provision close to home, and Sanjay's already talked about the clusters, the GP structuring that will enable more urgent care to be delivered by GPs and their clusters to you locally, closer to your point, to your homes. We want to create 2 new urgent treatment centres, and we want to base these, we propose basing these around the current emergency departments, in fact, in front of the front doors of those emergency departments at both Maidstone and Tunbridge Wells Hospital. And there we believe that we'll be providing primary care, primary urgent care, with the ability to escalate patients who need secondary care from those urgent treatment centres quickly into the emergency departments behind them. And we too want to strengthen the home treatment services and the home first services that provide care particularly to frail and elderly and chronically ill patients with multiple conditions, so that we can keep them at home within their communities and not make them one of the thousands of patients in hospital unnecessarily year by year. So the access points that I'm talking about, how do you get into the urgent treatment? How do you get urgent treatment? Well, GP surgeries will remain. We will still have those, and they will be clustered. And the primary source of resource for patients with an urgent treatment, an urgent need, will be their GP surgeries, usually by appointments, possibly by walk-in, but the clustering of those GP services will facilitate that. And indeed, you heard from Sanjay the intention to extend the availability of GPs to provide on-the-day appointments such that their urgent care needs can be met locally. 111 will remain our preferred option for getting into the system. We recognise that there have been difficulties with this. The service got off to a sluggish and difficult start. It wasn't well taken to by the public, and I think the initial reports were poor. But the good news is that over time that service has improved, it's learned from its mistakes, and generally your experience of NHS 111 is an improving experience. But I and my colleagues have been banging on for quite some time how this service can be made better still, mostly by putting what we call clinical intelligence into the service. The health advisors who currently take your calls follow a computer-based algorithm. But we've always felt that actually what you need is more clinical support behind that. And you will see as we go through this proposal how we intend to do that. And I think this will make NHS 111 the preferred option for people seeking urgent care. 999, that will remain pretty much as it is just now. But there will be the increased facility that if the paramedic attending you at home feels that you could be better treated within primary care, then it's not necessarily an automatic admission to emergency department. Increasingly, the paramedics will be able to treat you at home, to coordinate with your GP to facilitate that service at home, and indeed transfer you, we would hope, to the urgent treatment centres which we propose in order to allow you to stay within primary care and not necessarily be put into hospital if that's not the best place for you. And the urgent treatment centres, as I suggest, we propose these in front of the emergency departments, and the intention being that that will reduce the pressure on emergency departments from patients with primary care needs, so that those emergency departments can do what they do best, and that is treat patients with more critical illnesses that need the facilities of secondary care and the specialists that reside within secondary care. You've got this slide on your table, so if you can't see it, I apologise, but you've got it there. And essentially it's a summary slide of what we're proposing in this new system, another way of looking at it. And what we have is, in brown, the emergencies going through the 999, and in blue, those cases that we see as more urgent, going through 111, primary care, in hours, out of hours, and also not shown on the slide, the urgent treatment centres. So if we get the triangle of care, so in the first triangle, at the top of the triangle, you have the primary care services, where the GP-led clusters are shown and the urgent treatment centres are shown. 999 takes you more directly into the emergency departments, the two that we have with our local hospitals, and there behind it lie the surgical assessment units, the medical assessment units, paediatric assessment units, the frailty units, the specialist services available to those more critically ill patients. And for the most ill patients with specific problems, they will continue to be treated in specialist emergency departments. These are patients with heart attack, stroke, major trauma. The bubble at the top shows enablers for the system and other things that would back it up. So community pharmacy, the voluntary sector, the IT that would enable patients to do to utilise these services. The changes to NHS 111 are important. I'm just going to take a break to show you a video which encompasses the proposed changes to NHS 111 going forward. It will talk about that clinical intelligence, and it will mention the clinical assessment service that will reside in 111. So it'll describe the system as it is and the system that we propose. It goes really quickly and it requires quite a bit of concentration, but I think this is a good slide to encompass, to show what we're trying to do with NHS 111. Let's run that.
They are handled by a health advisor. Health advisors use a clinical decision-making support system and produce dispositions. Calls which are more difficult to handle as a result of complicated medical history or symptoms are handled by clinical advisors, nurses or paramedics. Dispositions are then passed electronically into the system. One of the problems that can occur is that those clinicians and professionals receiving the disposition lack confidence in their appropriateness. This results in patients going back to the front of the system. Transforming to integrated urgent care means a single entry point for patients. Calls will be handled by a health advisor who will also be supported by a clinical advisor working as part of the clinical assessment service, also known as the clinical hub. Within this, there will be a clinical navigator GP overseeing patient pathways and a range of healthcare practitioners. There will be generalists and specialists such as mental health and paediatric nurses, pharmacists, and those who are experts in palliative care. Some of these specialists won't be based in the service's physical location. Instead, they will be available virtually from wherever they are working. These may be specialists such as transplant specialists, renal specialists, and cancer specialists. The relationship with 999 is very important and will see full integration with integrated urgent care, both in terms of being able to dispatch ambulances directly from calls coming in via 111, but also by being able to provide clinical support and advice from the clinical assessment service to paramedics and ambulance clinicians. Health and care professionals working within the community, for example nursing homes, can not only refer patients into the clinical assessment service, but can also get support and advice from health and care professionals. The clinical assessment service will be able to produce an emergency department disposition, directly book appointments in and out of hours with GPs and other services. There will be access to specialists with video consultation for assessment and booking face-to-face appointments. For example, with a dentist, the mental health crisis team, a community pharmacist, or or an out-of-hours primary care or GP facility. The clinical advice service will also provide self-care advice to patients. Altogether, this is a transformed service which combines each element of the unscheduled urgent and emergency care systems for the benefit of patients.
So just to reiterate the points, the take-home points taken from that slide are this empowered multidisciplinary team behind NHS 111. So not only do we have the nurses and the paramedics providing advice, this is currently the point, but we're adding doctors, pharmacists and mental health workers, amongst others, and those virtual specialists in order to support the advice and the dispositions that NHS 111 currently offer to patients. Importantly is this issue about booking an appointment. So NHS 111 can now book you an appointment. The intention is that it will be able to book you an appointment directly into your GP surgery, into the out-of-hours GP, or into that into the urgent treatment centre, reducing waiting times and improving the flow of patients through these various facilities. Your healthcare information should be available with your permission through the IT facilities that we intend to develop and are currently developing in order to allow your records to be available to those involved in your care and making decisions and helping you make decisions about how best to proceed with the care offered. This will also be available online, so you'll be able to, for those of you more interested in the IT, be able to put yourself through those algorithms and help yourself to make relevant and logical decisions about how best you can be treated. In other words, NHS 111 online. The urgent treatment centres I've talked about, we want to place those in front of the front doors of Maidstone and Tunbridge Wells Hospital, providing a linked emergency and urgent care service. We pointed out how NHS 111 will be able to book you into these services directly. With regard to walk-in patients, we'll be looking at how we could best assess these patients to decide the priority of their care and what appointments could be offered to them as they walk in. No patient will be turned away from the urgent treatment centre in our current proposal. Out-of-hours services. Currently, we provide out-of-hours services through several points within in West Kent, and these are essentially GP services when your surgery is closed. Currently from Tunbridge, Cranbrook, and Sevenoaks, as well as the current provision at Maidstone. Maidstone out-of-hours service operates from the emergency department, linked to the emergency department at Maidstone Hospital. And this transpires to be a very successful model. Indeed, when we were discussing this in Maidstone very recently, there was general approval of how that system worked. By putting the out-of-hours service into Tunbridge Wells Hospital, which we're proposing, the logic is that you will have the out-of-hours service closely linked to the urgent treatment centre and the emergency department, allowing that escalation for the iller patients to happen very, very quickly. Local care will strengthen these services in the current sites in Tunbridge and in Sevenoaks, as you can see. There are no proposals to change the current facility in Sevenoaks with regard to out-of-hours services. We will have appointments into all these out-of-hours GP services, but I think the message here in terms of integrated urgent care is how these are closely linked to the urgent treatment services. I mentioned in that opening slide about the home treatment service, which we currently provide in Home First services. The home treatment service is a service particularly for more chronically ill, frail, elderly, often housebound patients, which by which we provide medical support to these patients to enable them to stay at home. And our intention within this proposal would be to expand that service. And the Home First service enables patients to be discharged more quickly from hospital with their assessments as to what support and services they need at home, occurring by a team made up of social services and therapeutic services. That sums up generally proposing a more integrated service, a less fragmented service, and I would particularly greatly value your feedback on our proposals. I'm going to hand back to